Good evening, everyone, and thank you for being here tonight. My name is Terri Wilcox, and I'm the co-founder and chief patient advocate at Patients Rising. Tonight, we're going to talk about a program most people have never heard of, a program that quietly moves more than $80 billion a year, at least it did in 2024, a program that was built for patients like you, and a program that today leaves patients almost completely in the dark. That program is called 340B. And by the end of tonight, you'll understand what it is, what's broken about how it touches your life, and exactly what Patients Rising is asking Congress to do about it, and how you can help. So let's get started. Now, here's the path we'll walk together tonight. First, we'll get our arms around what 340B actually is, when Congress created it, who it was designed to serve, and what it was supposed to accomplish. Second, we'll see the gap, because despite the program's size and its growth, patients today often can't tell where the savings go. In fact, no one really can, or whether a discount even applied to their own prescription. Now, mind you, it's a prescription that they created the revenue for the hospital for. They created the savings, and yet they don't know anything about it. Third, we'll get into the specifics of what our ask is, the three concrete fixes that Patients Rising is bringing to Congress this year. These aren't theoretical, they're written, they're targeted, and they're designed to give patients a seat at the table where, frankly, they haven't been. And fourth, we'll talk about you, about what you can do in the coming weeks, simple, specific actions to move this forward. What is 340B? Sounds like a tax form, as I always say. So let's start at the beginning. What is the 340B drug pricing program? Now, I want all of you to picture the year 1992, which I can, and it was a very good year. Congress had just expanded Medicaid's drug rebate program, a good thing for Medicaid patients, but it created an unintended consequence. Drug manufacturers facing those new rebates started raising prices on the safety net hospitals and clinics that served low-income and uninsured patients. The very providers that were stretching the most to take care of the most vulnerable were suddenly paying more for medications. Now, Congress saw this, and they acted. They passed Section 340B of the Public Health Service Act, part of the Veterans Health Care Act of 1992. And the deal was this. If a drug manufacturer wants to sell its medications to Medicaid, it also has to offer those same medications at a deep discount, typically 25 to 50%, sometimes even as high as 70% below market, to a defined list of safety net providers. Now, who qualifies? Federally qualified health centers, disproportionate share hospitals. Those are hospitals that serve a large share of low-income patients. Ryan White HIV and AIDS clinics, children's hospitals, rural clinical access hospitals, specific categories of providers serving specific patient populations. And here's the original intent. Now, this is the exact phrase Congress used. They wanted to, and I'm going to quote because it's very important, stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services, end quote. Now that's the promise. Stretch the dollars, reach more patients, provide more comprehensive care. Now hold that phrase in your mind, reaching more eligible patients. We're going to come back to it. Now, how's it supposed to work? Here's how 340B is supposed to work in 4 simple steps. Now bear with me. Step 1, a manufacturer sells outpatient drugs at the deep 340B discount. An outpatient drug is anything picked up at a pharmacy, you receive an infusion in an outpatient clinic, anything like that. That is an outpatient medication. Anything in the hospital is not included. Step 2, a safety net provider, let's say a community health center, buys the drug at the 340B price. Then they dispense it to a patient and bill the patient's insurance at the normal market rate. Step 3, The provider keeps the difference. That's the savings 340B generates. So if a drug costs the provider $30 under 340B, but reimburses at $100, the provider clears $70 of revenue. Now, step 4, and this is the whole point. Those savings are supposed to flow into patient benefit, more charity care, lower copays for low-income patients, patient assistance programs, transportation appointments, and its services in communities that don't have a lot of other options. That's the deal. Manufacturer gives a discount. Provider captures savings. Patients see the benefit. It's an elegant design. Honestly, when it works, it works. But here's the question every patient eventually asks once they find out about it. It's the question I built this whole webinar around. Does that fourth step actually happen? When the savings are generated, do they really reach the people the program was designed to serve? We don't know. And that's the problem. So now, let me give you a sense of scale, because this is no longer 1992. In 2024, the most recent full year of data, covered entities purchased $81 billion, that's a B, dollars in outpatient drugs under 340B. And that number grew about 23% in just 1 year. So pretty soon we're going to find out 2025, and I can guarantee you it'll probably be more than 100 billion. There are now more than 50,000 covered entities in the program, hospitals, clinics, and the affiliated locations they operate, and there are more than 32,000 contract pharmacies. Those are retail pharmacies that the covered entities have agreements with to dispense B medications on their behalf. In 2014, the program was about $9 billion. By 2018, it was $24 billion. 2021, $44. 2023, $66 billion. 2024, $81 billion. This is one of the fastest growing components of the entire U.S. drug spend. And here's the thing. We're not telling you 340B is bad. We're not saying it's gotten too big, though it has. What we're saying is that a program this large, with this many participants, moving this much money, has to be able to answer one simple question. Where did the money go? Where did the savings go? Where did the revenue grow? And right now, it can't do that. It simply can't do that. So that's the question we keep coming back to. Where did the savings actually go? $81 billion flows through 340B every single year. And patients, the people the program was built for, can't tell 3 basic things: how much was saved, where the money went, and whether they personally benefited from any of it. This isn't conjecture. This isn't an opinion. 2 of the most respected nonpartisan watchdogs in the federal government have flagged this for years. The Government Accountability Office, which is the GAO, many of you probably have heard of that, has consistently found that HRSA's oversight of 340B has been limited. The agency that runs the program hasn't had a clear ability to verify how covered entities are actually using their 340B revenue. That's not me saying it. That's GAO. The HHS Office of Inspector General, the OIG, has reached similar conclusions. Public data on 340B savings and patient benefit are insufficient to demonstrate the program is meeting its safety net mission. Insufficient. That's the word. Now, I want to be careful here. Both of those findings are about the data and not about the providers. There are many, many covered entities doing extraordinary work for their communities under 340B. The point is that we as a country cannot prove it from the public record. And in a program this big, that's a real problem. If a program of this size can't show its work, it becomes a target. Critics fill the silence. Defenders end up arguing on the back foot. And patients, the people this is all supposed to be about, are left out of the conversation entirely. Now that's the problem we want to try to solve. Now, here are two gaps. When we got serious about this issue, we found that what patients are actually missing breaks down into two specific gaps. We call them the transparency gap and the awareness gap. Now, let me explain each one. The transparency gap is at the institutional level. It asks, where did the savings go? Right now, covered entities are not required to publicly report how much they save under 340B. They're not required to break down what share of those savings reach patient care versus what share goes to other institutional uses. So if you're a patient or a community member or a state legislator and you want to know what 340B is producing in your community, you mostly can't find out. There's no standardized public report. The data simply isn't there. That's the transparency gap. That's the accountability gap. Then there's the awareness gap. And this one is more personal. The awareness gap asks, was 340B even used on my prescription? And the honest answer for most patients is, you have no idea. The pharmacy doesn't tell you. The receipt doesn't say so. The clinic doesn't note it on the paperwork. The discount is invisible to the patient at the point of sale. So even if a 340B drug saved your hospital $500 or $5,000 on your medication, you may have paid the same copay or coinsurance or whatever you owed, you'd have paid anywhere else. You walk out and you have no way to ask the right follow-up questions, no way to connect what's happening to you with what's happening in this giant federal program designed for you. That's the awareness gap. And here's the painful irony. The very people the program was built to serve, low-income patients, uninsured patients, patients in underserved communities, are the people with the least information about it. Patients are essentially invisible inside a program that exists in their name. Now, we can fix that, or we can try to convince Congress to. And our proposal lays out exactly how. Our ask, a new patient line. Actually, a new patient lane. A new patient lane. So here's what we're asking for. For the fiscal year 2027 appropriations cycle, that's the Labor, HHS, and Education Appropriations Bill, Patients Rising is asking Congress to include report language directing HRSA's Office of Pharmacy Affairs to take 3 specific actions. We're also asking for $3 million in directed funding to make it possible. $3 million in a program that moves $81 billion to finally give patients visibility. We're calling this a new patient lane because right now, the conversation about 340B happens between manufacturers, between hospitals, between policymakers, between trade associations. It happens in courtrooms. It happens in HRSA rulemakings. It mostly doesn't happen with patients, even though it all happens because of patients. We're creating that lane. That's the lane we want to see. The 3 actions are: number 1, public reporting on where savings actually go. Number 2, point of sale notifications so patients know when 340B applies. And number 3, 180-day report back to Congress on progress and any further legislative changes that are needed, meaning, do we need to pass legislation to give it teeth? Most likely we do. But we want to start here. I'm going to take each one of those things in turn because I want you to understand exactly what we're asking for and why. None of them are radical. None of them are takeaways. All of them are about visibility. So ask 1. Show us where the savings actually go. Public reporting. Right now, the public record for where 340B savings go is mostly silent. Some covered entities choose to share information voluntarily, others don't. There is no standardized comparable public data set. You cannot pull up a report and see what 340B produced in your community last year. And quite frankly, given the massive property and other tax breaks they receive as a nonprofit entity, you should. Everyone should. We're asking HRSA to develop a public reporting framework using the authority HRSA already has and flagging for Congress any additional authority they need. Under this framework, covered entities would report annually on three things and where contract pharmacy arrangements are involved. Those savings would be reported to A. Total B savings generated. How much discount value did this entity capture in the reporting year? A number. All we're asking for is a number from each entity. Allocation of those savings to direct patient benefit. Of that total, how much of it actually translated into care, cost relief, and support for patients? And number 3, the share of savings used for patient care relative to other institutional purposes, because covered entities have many costs. Some 340B money may go to general operations, debt service, expansion projects, who knows? That's not necessarily wrong, depending on the entity. But the public has a right to see the breakdown. That's it. 3 numbers, done annually, public. Why does it matter so much? Because if the program is doing what it's supposed to do, this reporting will prove it. It will make the safety net case in public. Every dollar that does flow to patient benefit becomes visible, becomes defensible. And on the flip side, if there are entities where the savings aren't reaching patients, we can have an honest conversation about why and what to do about it. You can't fix what you can't see, and right now, no one can see it. Defining direct patient benefit. Now, this is important. For that reporting to be meaningful, we have to pin down what direct patient benefit actually means. If you just write patient benefit into a statute or a regulation, every covered entity gets to define it however they want. It can quietly come to mean almost anything. That's how transparency proposals get watered down to nothing. So our proposal does the work. It defines direct patient benefit to include 5 specific categories. Number 1, lower out-of-pocket cost. Reduce copays, deductibles, and self-pay prices for patients. Direct dollar-for-dollar relief. Number 2, charity care. What is charity care? Free or reduced cost care for low-income and uninsured patients. It's the classic safety net function. Number 3, patient assistance programs. Direct programs that help patients afford their medications and treatments, not just discounts on the drugs the entity bought, but support that touches the patient. 4, transportation and patient support services, rides to appointments, language services, care coordination, patient navigators, all the things that make care actually accessible, not just theoretically available. And many of these things are the things that go by the wayside in smaller rural hospitals, disproportionate share hospitals. This is what it was made for those things in the hospitals that can't afford it, the hospitals that are struggling, not the billion-dollar hospitals overlooking a lake or a river or an ocean. And 5, expanded access to care in medically underserved areas. New clinics, extended hours, mobile health services, bringing care to communities that don't have it, not building centers in communities that are wealthy and upper middle class and already have lots of resources and lots of places to go for care. These aren't novel concepts. These are the things 3B was always supposed to enable. We're just naming them. So reporting against them is meaningful. The point of the definition is precision. Without it, you get vagueness, and with it, you get accountability. And that's what we're all about. We want the 340B program to be accountable to the patients it was supposed to serve. Ask number 2, point of sale notifications. Tell the patient when the 340B discount is applied or when they're a 340B patient. Tell patients at the moment it matters when 340B has been applied. That's it. This is so simple it almost feels obvious and you wonder why it hasn't been done before, but it has never been done. We're asking HRSA to develop and pilot feasible mechanisms for informing patients when their medication was purchased under the 340B program. The exact design would come out of the pilot. It might look like a flag on a pharmacy receipt. It might be a small notification on a printed summary. It might be something integrated into a patient portal. We're not prescribing the answer. We're asking HRSA to figure out the best way. You can see one possible version right here in the slide, a normal pharmacy receipt. That's not totally normal. I mean, it's designed, but has these things on it: patient name, medication, 30 tablets, the price, the copay. And then at the bottom, there could be a clear notice. This medication was purchased under the 340B drug pricing program. Imagine that. For the first time, patients would actually know when 340B is touching their care. Not as a footnote in a federal report, not as something they read about in the news, but right there on the receipt they hold in their hand. And we recognize this is more complicated than it looks. I understand that. There are operational realities, there are pharmacy systems, claim processing, multiple supply chain steps. I do understand that. There are patient privacy considerations, possibly. There's the question of how to communicate clearly without creating confusion or alarm. That's exactly why our proposal asks for a pilot. To work through all of that carefully with covered entities, contract pharmacies, manufacturers, and patient organizations all at the table. This single change would do something profound. It would put patients back into the conversation about their own care. It would let them ask their providers the right questions. It would create the demand side awareness that this program has needed for more than 30 years. Ask number 3, 180-day report. The third ask is the simplest, but it's what makes everything else stick. We're asking that within 180 days of the Appropriations Bill being enacted, HRSA submits a report back to the Appropriations Committee. That report would describe implementation progress on the public reporting framework, on the patient notification pilot, identified challenges, and critically, any legislative change the department believes are necessary to fulfill 340B's safety net mission. Meaning, do we need legislation? And believe it or not, Patients Rising already has a fix for that. 180 days is the timeline. Day 0, the bill passes. Days 1 through 179, HRSA builds the framework, designs the pilot, engages the stakeholders. Day 180, they report. This piece matters because we don't want this to become a study that sits on a shelf. We want feedback loops. We want HRSA telling Congress on the record, here's what we need. If something needs to change in the underlying statute, we want to hear it. If something is harder than expected, we want to know. If something is working, we want it celebrated. Let's do more of that, the things that are working. Real accountability, real transparency, and real movement on a program that is literally in a black box. So what this is and what it isn't. Now, I want to say something important because the moment you propose anything around 340B, people line up on every side and start swinging. So let me be crystal clear about what this proposal is and what it is not. This is a transparency and accountability proposal, not a takeaway. It is meant to strengthen 340B's safety net mission, not narrow it. What this is public reporting on where 340B savings go. It is clear definitions so that patient benefit means something specific and measurable. It is letting patients know when 340B applies to them. It is a 180-day report back to Congress with real accountability. And it is a constructive, patient-focused conversation in a debate that has gotten very loud and very angry. Now, what it is not. This is not changing who's eligible for 340B. We are not touching the eligibility list. This is not rolling back coverage on safety net providers. They all remain in the program, provided they deserve to be in the program. This is not cutting hospital or clinic funding. This is not picking a side in the ongoing battles and disputes that you read about in the litigation. And this is not a vehicle for unrelated policy changes. This is one thing. It's visibility for patients. That's it. Visibility so that a program designed in their name can show its work. I'll say this directly. Patients Rising supports the FY27's mission. Hospitals and clinics serving safety net populations are doing essential work. We want them to continue. We want them to have the resources they need. We just want patients to have a seat at the table. And we want the program to be able to demonstrate publicly that the patients it was built for are actually being served. Now, why this matters to you. Now, I want to bring this home. I've got one more slide after this. If you have any questions, put them over in the chat. I'm going to bring this home. Why does any of this matter in your life? I have 6 reasons. First, you deserve to see the savings. If your medication was discounted through 340B, you should be able to see whether that discount reached you in any way. That is not an unreasonable thing to ask. After all, you're generating the revenue with your prescription. Second, patients funded this promise. The entire rationale for 340B is a public good for patient care. The growth of the program is justified to Congress, to taxpayers, and to manufacturers on the basis that it benefits patients. Transparency and accountability is how that promise stays honest over time. Number 3, underserved communities benefit the most from clarity. The communities the program was originally designed to reach, rural areas, low-income urban neighborhoods, communities with high rates of chronic illness, those are the communities where the safety net matters most. Clearer data means we can see whether 340B is actually getting to those communities or whether the dollars are being absorbed elsewhere. Fourth, good programs survive scrutiny. If you believe in 340B, and we do, then you should want it to be able to defend itself in the open. Transparency and accountability strengthens the program against the people who want to gut it. I don't really think there are that many people who want to gut it. I actually think that there are people who want to save it, which is what we're trying to do, to make it stronger, to make it better, to make it what it was originally meant to be. It makes the safety net case in public with numbers. That's what we're trying to do. Number 5, a real seat at the table for patients. For too long, this debate has happened over patients' heads. Manufacturers and hospitals fight each other. Policymakers try to referee. Patients are talked about, but rarely talked with. This proposal creates a patient-focused lane in a debate that has needed one for a long time. And number 6, trust is rebuilt or built by showing your work. When patients can see what the system is doing, they engage with it. They defend it. They support it. Silence corrodes trust. Transparency and accountability, that stores it. This isn't just policy. This is whether the safety net promise still means something. Slide 15 is our final slide. And this is where we're going to talk a little bit about how you can take action, the things we're going to do in the coming weeks. Number 1, we're going to provide a toolkit for this. I'll have it by the end of the week on the website along with this recording. You can call your member of Congress or your senator. Tell them in your own words that you support including patient transparency and accountability report language in the fiscal year 2027 Labor HHS Education Appropriations Bill. If you're in this Patients Rising community, I have put the list of all of the members of Congress that are on that committee. If you live in any of those districts, it would be especially helpful. The more constituent voices on this, the more weight it carries when staff is putting that bill together. We'll have a template for you both inside the Patients Rising community and on the website where this webinar will live. But I honestly believe your own words are the most powerful. So take the toolkit as we usually do and read it, absorb it, get as much of the lingo and familiarity with the bill and with the, with what you're advocating for, and then make the pitch or make the, tell your story and ask 340B reform, I guess you could call it. I don't really like to call it reform because it's really creating accountability and transparency for a program that we believe is good. Now, number 2, it says share your 340B story. And I always tell everybody who asks me, do you have anybody with a 340B story? Not very many people have a 340B story because we're just now getting the word out about 340B. So if you've ever wondered where a discount went, if you've ever paid more than you expected at the pharmacy, if you ever struggled to figure out how the financial side of your care actually works, that's the kind of story that moves this conversation forward. If you've ever been in a hospital and left with tons of bills, we're doing a whole series on medical bankruptcy in America at Patients Rising. You should check that out because it covers a lot of the 3B hospitals that are sending patients into collections, and ultimately they're ending up in bankruptcy court. So patient stories, however you can weave in your patient story, they drive the policy. So you can email us, you can post about it, you can tell us. And number 3, you can come join the Patients Rising community, the Patient Senate. We're building a coalition of patients who want visibility, accountability, and a real seat at the table on 340B. The more of us there are, the harder we are to ignore. And that's it. That's the whole ask of you tonight. Make a call, share a story, join our coalition. I thank you all for being here. I thank you for caring about this. And now, if anyone has any questions, I'd love to hear them. It looks like I do have. A lot of patients actually know about them. Well, that's a very good question. Here's the question. How do patients actually know about 340B? Is it from the pharmacy or prescribing doctor? I never heard about this except through advocacy, maybe because I don't qualify. No, that actually has nothing to do with it because there are no qualifications. That's the whole point of this. The 340B revenue, the original statute says that it's supposed to be used for community benefit. Now, I don't want to say any names here or anything like that, but community benefit can mean literally anything. It can mean we're going to put our name on a football stadium in the community. Doesn't necessarily mean that we're going to serve vulnerable patients or, make sure that our rural centers and other centers have all of the things that they need. But regardless, we believe, and that's in the language and the things that we're asking, is that even if you aren't in need in that way, even if you don't live in one of those communities, but you're generating, for whatever reason, 340B savings, because see, technically, a 340B patient, is supposed to be somebody in those categories, right? That's technically what it's supposed to be. But since we don't know, and there's all sorts of programs out there now, but there's actually programs and ways that there's companies that help hospitals go back even years and collect the discounts retroactively, go back and collect their savings. So what we're asking, the reason you don't know about it is that's by design. You not knowing about it is absolutely 100% by design. And because of that, they're able to build more places for patients to go in upper middle class neighborhoods or, wealthier neighborhoods where they know they're going to make more money. And they starve, in some instances, and you can read things like the Bon Secours story out of Virginia. You can read all of these things and they'll starve those entities. Even though they're 340B, those are the entities where the dollar should be flowing. And that's what we're asking. That's why we're asking to start with. It's like, give us your number. How much savings are you generating? How much revenue are you entity who's 340B qualified generating? And when you're generating that, what are you doing with it? And on the flip side of that, we believe that the patients who are generating the revenue should know about it. They wouldn't even be making that revenue or have that savings without you and your medication and the discount they receive because of that. So the answer to the question in a short is you don't know because they don't want you to know. And I'm hoping that will change over the next several years, like many things. Not a lot of people knew what a PBM was a decade ago, but now most people who have medications do. That is the goal of this. But that was a great question because you don't know. And that's what we're asking. So just so everyone knows, I'm going to wrap it up. It doesn't look like there's any more questions. I was pretty comprehensive, but if anyone has any more, feel free to ask. I'm going to have a toolkit. I will have the entire webinar tonight up I'll put it both in the community and I'll do a blog post about it and have it up on the website. And we'll have a landing page for this campaign as we get it going. I will be publishing the report language, hopefully over the next couple of weeks. We're trying to finalize it now. We have a few more tweaks to it. But I just wanted to get everyone started and have this. I haven't had a real comprehensive 340B webinar, so I hope everyone got something out of this. And if you have any questions, you know where I am, especially if you're in the community, just ping me, email me, Terri@patientsrising.org. It's not that hard. So anyway, thank you all so much. And I appreciate all of you who are able to come tonight. And for those of you who weren't able to come tonight and you watched all the way to here, I appreciate you too. So have a great evening.